Thank you so much for giving me the opportunity to be here today to share with you what we have learned about relapsing polychondritis. I have no disclosures, and I would like to start with a case. This was a 32-year-old male with intermittent left wrist MCP and right knee arthritis. He also had costochondritis, including the xiphoid process, difficulty swallowing and shortness of breath, and he was found to have a swollen epiglottis by direct laryngoscopy. He also had dizziness, tinnitus, and hearing loss, and had intermittent episodes of ear and nose pain, redness, and swelling. And this is the picture of this patient. This is the first case that was ever described in the literature of a patient with relapsing polychondritis. And you can see here, he had a saddle nose deformity, and you kind of like see the cauliflower ear. And I always like to title this slide, "It was not the beer." And the reason that I do that is because the author of this case concluded that the reason that this patient was having relapsing polychondritis was because he was drinking too much beer. This patient happened to be a brewer, and apparently he was drinking 8 liters of beer per day, probably because he was in so much pain. We have not been able to find a link between drinking beer and relapsing polychondritis. So probably that wasn't the cause. So relapsing polychondritis is all been recognized, and most people will think that the main feature that is associated with RP is a swollen ear. And a common belief is that the diagnosis needs to rely primarily in this clinical feature. And while ear inflammation is a common clinical manifestation of relapsing polychondritis, the appearance of these clinical symptoms can happen late in the disease. We, for example, have patients that had relapsing polychondritis that was diagnosed when they were very young, like teenagers, and they only had ear chondritis when they were late in their 30s. So relapsing polychondritis is more an inflammatory disease of unknown etiology that affects multiple organs, and unknown etiology for most of the different clinical subtypes of relapsing polychondritis. I'm going to be sharing with you close to the end of the talk a new discovery from NIH, which is a new syndrome called VEXAS, which basically explain a particular subgroup of patients with relapsing polychondritis in terms of the etiology. So what is the organ involvement in relapsing polychondritis? It affects the cartilaginous structures, as we all know. That's why we call it polychondritis. So it affects the ear, as I mentioned before. I will be talking more about the ear in the next few slides. And the nose. The nose chondritis symptoms are sometimes very subtle and difficult to recognize because patients sometimes can have pressure and pain, and then when you take a look at the physical exam, you won't see much. What I'm trying to show here is a little bit of erythema and swelling at the bridge of the nose, and what patients usually describe is that they feel that somebody has like punched them on the nose, and is like right in the middle at the bridge of the nose. They can also have rhinorrhea. It's been diagnosed with previous many episodes of sinusitis, and they can have crusting, not as bad as patients with GPA, and actually the location of the crusting is more at the septum, but they can also have that. And the musculoskeletal system, it affects all the joints, so it does not have a predilection for a particular joint. It small joints, large joints. And then what I'm trying to show here is dactylitis, which is something that patients with RP can also have, and we also have found some patients that have evidence of sacroiliitis. And the most common joint, I will say, is the costochondrial joints, including not only the anterior aspect, but also the lower ribs, which is sometimes also difficult to recognize. Patients can have involvement on the upper airway. So this is an example of subglottic stenosis, and this is a picture of some of the cartilaginous structures in the upper airway. I will be spending more time talking about the airway manifestations in the next few slides as well. And the lower airway, which include the trachea and the bronchi, leading to tracheomalacia and bronchomalacia. And most interestingly, it can give the patients air trapping. And the reason of that is because the cartilage in the airway actually goes all the way down to the smaller bronchi. So like any other cartilaginous structure can get inflamed, and I think that that leads to the air trapping. We're still trying to figure out the exact component of the air trapping and the distal airway inflammation in patients with relapsing polychondritis. So RP has a predilection for cartilaginous structures, but it doesn't have a predilection for any particular type of cartilage. So it affects all of them, right? Hyaline, elastic, fibrocartilage, all of the cartilage in the body can be affected due to relapsing polychondritis. Eyes, the most common manifestations are scleritis, episcleritis, and uveitis, being episcleritis the most common, but the most severe is scleritis that sometimes can be very difficult to treat. The central nervous system can also be affected. It's very rare. It's more common in men, and they respond very well to high doses of steroids. And the most common manifestation will be limbic encephalitis. The inner ear also gets affected, leading to dizziness, tinnitus, and hearing loss. Heart valves, the vascular system, mainly the mitral valve and the aortic valve, is also very rare and more common in men, as well as aortitis. I think the vascular involvement in relapsing polychondritis was still in the process of trying to understand what is the extent, but we believe that is a variable vessel involvement. And the skin can also be affected in these patients, in particular patients that have this new syndrome called VEXAS, that we're going to talk about that later. So relapsing polychondritis is a systemic inflammatory rare disease that has a predilection for cartilaginous structures and is very heterogeneous. And I want to highlight that this disease is very heterogeneous, and that is one of the serial issues that this condition can have, because by being an heterogeneous condition is very difficult to diagnose, to recognize, and that's why I think that this is probably more than one disease, because of the way that this disease is being diagnosed and how heterogeneous it is. And we try to study the difficulty of diagnosing relapsing polychondritis, and we wanted to answer this question. So we did a survey with the help of the Relapsing Polychondritis Foundation. This was a few years ago. This was an international survey that included 304 patients. And what we found was that more than 50% of the patients, so more than 3 physicians prior to getting a diagnosis of relapsing polychondritis, and more than 50% of the patients had to go to emergency room prior to the diagnosis because of symptoms due to relapsing polychondritis. And the most common symptoms included ear pain, shortness of breath, pleuritic chest pain, and costochondritis. So the next thing that we wanted to do with this data is try to figure out what would be the factors that could be associated with a delay in diagnosis. Because as I show you on the initial slides, the most common symptom and the recognition of the disease relies on the ear chondritis. So we wanted to find out if that was true in terms of delay of diagnosis, and that is exactly what we found. So by doing multivariable logistic regression, we found that absence of ear and nose involvement was associated with delay in diagnosis, as well as having a previous diagnosis of fibromyalgia. And again, the reason that this disease is difficult to diagnose and is so heterogeneous is because of the way that you diagnose currently relapsing polychondritis. So this is a purely clinical diagnosis. And then this is how you diagnose RP. These are the clinical symptoms that you need to have to be diagnosed with RP: bilateral auricular chondritis, nasal cartilage inflammation, respiratory tract chondritis, non-erosive polyarthritis, seronegative polyarthritis, ocular inflammation, and audiovestibular involvement. So McAdams in 1976, with the data of 23 patients, came up with the criteria for RP, which is if you have 3 out of 6, you will meet criteria for RP. For example, you can have nasal cartilage inflammation, respiratory tract chondritis, and non-erosive seronegative polyarthritis, and you will meet criteria for RP. And as you can see, I did not include it bilateral auricular chondritis. Then Damianis in 1979 modified this criteria with data of 10 patients. So the Damianis criteria is if you have the McAdams, if you meet McAdams, or if you have a clinical symptom and a biopsy that is showing inflammation on the cartilaginous structures, or if you have 2 of the clinical symptoms with response to steroids or Dapsone. Now you see Dapsone is included here because this criteria is from 1979. So, this clinical diagnosis has several issues. So one of the issues is that we are diagnosing patients purely clinical, but we do not have a clear definition of this organ involvement. This has not been validated prospectively, and as I mentioned to you before, this was done in very small cohorts. So let's take, for example, bilateral auricular chondritis. And then I am very lucky because I had many patients that were very, very generous and share with me all the pictures of their ears. The question is, what is ear chondritis, right? This is the main symptom to recognize this disease, and yet we don't have a clear definition. Is ear chondritis a cauliflower ear? Do we have to wait until it gets damaged? So, for example, here I want to show you some of these pictures and highlight it for you. So you see, this patient has a diagnosis of RP, but you take a look at the ear, and the whole ear is red, right? So the belief is that you need to have sparing of the lobe, but we see this in many patients. We see many patients that have the whole ear that is red. Yeah, we take a look at this one. This is more like the typical one that you want to see where you don't have a sparing of the lobe. But then if you take a look at this other picture, this patient had so much inflammation that it actually got into her face. So as you could see, the idea that ear chondritis is basically the triad is the redness, swelling, and pain only on the cartilaginous structures is probably not what we think it is. And then to be able to answer that question, we also conducted another survey. This is more recent. This was a different survey, also with the help of the Relapsing Polychondritis Foundation. It was presented at the ACR this year, trying to define what is ear chondritis and understand these symptoms from the patients better. And this is data from 685 patients. And this is what we found. So we found, this is a percentage. So we found that, for example, the duration of the pain was very variable. So it was not there was not a consistent symptom description for all the patients overall. Basically, everything was like all over the place. So many physicians believe that you need to have ear chondritis for more than 2 to 3 days to be able to call it ear chondritis. But then you look at the answer from the patients, and 30% of the patients actually had ear chondritis only for a few hours, and some of them had it for more than 7 days. When we take a look at the location of the pain, yes, the majority of the patients localize the pain on the pinna, but many of the patients also localize the pain in the inside of the ear, behind the ear, and the whole ear. And the onset of the pain was very variable, right? So it was like it could be sudden, it could be gradual, it could be between sudden and gradual, it could be different between each episode. And the aggravating factor, I was expecting a little bit more in terms of the temperature, because I think that may be perhaps a component, but the most common aggravating factor was minimal trauma, meaning laying on the ear. So, and for example, would you call ear chondritis someone that is having ear pain, that it wakes her or wake him up in the middle of the night and you have a little bit of redness and swelling? I will call that ear chondritis, because I don't think that is normal that you have ear pain that wakes you up in the middle of the night. But we still haven't defined ear chondritis. We're working on that though. So now I would like to go on the next case. This is a 31-year-old woman with cough, shortness of breath, arthralgias, costochondritis, and weight loss. She was diagnosed with asthma, previously treated with bronchodilators, but she didn't respond to the bronchodilators. And on the physical exam, she had hoarseness, sacroiliac joint pain, wheezing. The chest X-ray was normal, but she continued to have worsening of symptoms. So she went to the emergency room, and unfortunately, she needed to be intubated emergently, and she was found to have tracheal collapse, inflammation of the bronchi, nose cartilage inflammation, and synovitis. She did not have auricular cartilage inflammation. So what is the airway involvement in relapsing polychondritis? The prevalence is about 20 to 50%, depending on the case series or study that you look at. Airway symptoms can be the first manifestation of the disease, and that include cough, stridor, and hoarseness. Patients with airway involvement can have delay in the diagnosis. They tend to be younger, and they have more ICU admissions and complications. They tend to have a previous diagnosis of adult onset asthma, and the complications could be severe. So it could be subpleural stenosis or focal and diffuse malacia. So I'd like to take the opportunity now to talk about a little bit of the cartilage in the upper airway. And the reason that I'm showing these pictures is because I think that it helps understand maybe some of the symptoms that patients with relapsing polychondritis can have. So we take a look at the epiglottis, and we have the thyroid cartilage. So the epiglottis is easy to visualize, right? You do direct laryngoscopy and then you could see it. But the thyroid cartilage, you can see it, right? It's super difficult to visualize. We have tried to do MRI with and without contrast and CT scan, but the structure is very thin, and there is no one that has an expertise looking at these particular structures. But patients with relapsing polychondritis often will complain of pain in the anterior part of the neck, and some of them will have erythema in that area. And I believe that is because this gigantic piece of cartilage is inflamed. On the lower aspect of the larynx, you will find the cricoid cartilage. And the cricoid cartilage is a very interesting in structure because it's a circumferential cartilage. And many patients with relapsing polychondritis sometimes will complain of having or feeling a choking sensation. Right, so if the choking sensation coming and a sensation of globus. So that could be coming either from the epiglottis or the cricoid cartilage. That is also very difficult to visualize because it's outside the airway, so you can't see it directly. And the arytenoids. So we have been trying, and all the patients, when they come to NIH, we look at the upper airway with ENT, and then we're trying to understand how the arytenoid inflammation is related to disease activity in relapsing polychondritis. And one of the issues that we have encountered is that arytenoid swelling can also happen when you have GERD, which is a very common in the regular population, how many people have GERD. So it's very, we're still in the process of trying to figure out, but we have seen a few patients where arytenoid swelling gets better after treatment for RP. These are some pictures of the upper airway visualization. So this is a picture of an ulcer on the septum, as I was saying to you before. It seems that the disease in relapsing polychondritis affects more the septum rather than the mucosa. See, in GPA, you see the crusting in the mucosa. In RP is like more mild and more on the septum, and that makes sense because that is where the cartilage is. And then this is a picture of a perforation on the septum. Interestingly, patients with relapsing polychondritis, they don't have a statal nose deformity when they have nasal perforation. We have 3 patients in our cohort that have a nasal perforation and they don't have statal nose deformity. The statal nose deformity in RP seems to be because the cartilage in the nose, it gets damaged, but without the perforation, which is a difference with patients that have GPA. This is another picture of the upper airway visualization. So I'm showing you the arytenoids, the vocal cords, and the subpleuric space. And this is an example that I showed you before of a patient with severe subpleuric stenosis. So these are the ones that sometimes look a little bit red and swollen, and then I think that it could be related to disease activity. Now, I just want to show you some pictures of the cartilage in the lower airway. So this is the trachea, and then the trachea has a partial rings of cartilage and a posterior wall. And what it usually gets affected in relapsing polychondritis is the cartilaginous structure. So it will be the anterior aspect of the trachea. And patients can have different things. They can have thickening of the trachea. You consider thickening of the trachea when it's more than 3 millimeters. There is some controversy between 2 to 3 millimeters, but after reviewing several studies and what people say, we decided that it's 3 millimeters. So if you have a thickening more than 3 millimeters, you consider that abnormal. And you can have calcification, and you can have damage of the trachea without thickening, which we call it a tracheomalacia. That could be an anterior collapse or lateral collapse. The posterior wall of the trachea collapses normally during expiration, but you can have excessive collapse of the posterior wall. Some experts in tracheomalacia will call that also tracheomalacia, but that is more excessive collapse of the posterior wall of the trachea. We also have seen that in patients with RP. So you could see combination of damage of the trachea and posterior wall collapse. And if you have collapse of more than 50%, you will call that tracheomalacia. But again, it could be a combination of the collapse of the cartilaginous structures and the posterior wall. And we have seen improvement on the collapse of the posterior wall. So we're still trying to understand if this is also secondary to the different pressures that you have in the respiratory system. And the reason of that, again, is because you have cartilaginous structures that cover the bronchi all the way down to the small bronchi. So when these gets inflamed, I believe that patients get air trapping. And that's why this patient gets an adult onset diagnosis of asthma. Here, I wanted to show you an example of the dynamic CT scan that we perform at NIH. So you could see here the posterior wall is collapsing, and it should. There is some attenuation in the lung parenchyma that are secondary to the air trapping, and there is a little bit of collapse on this part. This patient had more collapse in a different location of the trachea, but this is an example of the dynamic CT scan that we perform at NIH to evaluate the trachea and the bronchi and lung parenchyma. This is an example of a tracheal calcification in one of our patients. And this is an MRI of one of our patients showing inflammation in the upper trachea. So again, we have been trying to do different type of images to try to identify the inflammatory process on the extra airway cartilaginous structures, but it has not been easy to identify those. So now I would like to go to another case. This is a 38-year-old woman with a genital and oral ulcers. She also had ear pain that wakes her up at night with mild redness, dry cough, and shortness of breath. And she got a diagnosis of adult onset asthma. On physical exam, she was evaluated by GYN, and she has scars from previous genital lesions. She was also found to have synovitis in multiple joints, and the dynamic CT scan showed tracheomalacia. So this patient has a diagnosis of MAGIC syndrome, which is mouth and genital ulcers with inflammation of the cartilage. And MAGIC syndrome was first described in 1985. There were like 5 cases in this case series. And there is not a particular definition of this entity. Is rare. So there is case reports and case series in the literature, but we believe that this is it is an overlap between relapsing polychondritis and Behçet's, and we are in the process of trying to understand this entity better. I do have a bias towards RP. So to me, all of the conditions that have chondritis, there are subtypes of relapsing polychondritis. But MAGIC syndrome may be its own entity. We're still, again, in the process of trying to understand this better. So this is data that was presented by Yiming Luo, which is one of the fellows at NIAMS and at ACR. And then we look at the patients that meet criteria for MAGIC syndrome in our cohort. And then what we found was that patients that have MAGIC syndrome had a delay in diagnosis. And we also found that patients with MAGIC syndrome have different clinical manifestation when you compare them with patients that have RP. For example, they have more gastrointestinal symptoms, they have more cutaneous involvement, more aortitis, more DVTs and PEs, more airway chondritis, nose chondritis, Raynaud's, oral ulcers, of course, and genital ulcers, and eye involvement. The three variables that were statistically significant included Raynaud's, oral ulcers, and genital ulcers. But it seems that these patients may be different than patients that have only RP. So as you can see, relapsing polychondritis have multiple phenotypes. And this has been well known in the literature. So experts in relapsing polychondritis have tried to identify these over the years. So this idea is not new. For example, Dion and collaborators in France, they did a cluster analysis in 142 patients retrospectively, and they identified three particular subgroups. And that was a hematologic subgroup that I'm going to be talking about that later, the mild group, and the respiratory group. The mild group was not by any means really mild. These patients all have disability, and they have to take a lot of medications. But the reason that it was called mild is because they did not have that much mortality of admissions to the ICU or other further complications. Shimizu from Japan did a survey in he sent a survey to all the physicians and many physicians to answer all the questions regarding the patient's symptoms. So that included 239 patients. And then he did a supervised approach, meaning that he predefined the organ involvement before he took a look at this data. And then he defined three different groups. One was the auricular group, the other one was an overlap, and the third one was respiratory. And we also tried to do that in the survey that I showed you at the beginning. And then we identified three different groups, and that was the patients that have ear and nose chondritis, mainly joint involvement, and respiratory. And we did this also by doing cluster analysis. So as you could see, the respiratory subgroup, it has been consistent, regardless of how you look at this identification of clinical subgroups. So that is great because it's data that it was generated with large number of patients, but all of these studies had some issues, right? So this one was retrospective. This one was, a predefined approach, which, I mean, there is nothing wrong with that, but there was all the data was collected by answering surveys and not directly from the patients. And the comparison of the groups was not between the three groups at the same time. And our study also, it was not ideal because we did not have the primary data from the patients. So in order to look at these clinical subtypes again, we decided to do this in our prospective cohort by doing latent class analysis. And then we chose to do latent class analysis, which is a method designed to uncover different variables in a data set, because we had a lot of data that it was like very complete. The evaluations were standardized and everything was prospective. And we used 6 variables to include in the latent class, and that we chose these variables because these were variables that were suggestive of damage. So we included saddle nose deformity, tracheomalacia, bronchomalacia, ear involvement, and tenosynovitis. So objective data. And we found 3 different subgroups. And this picture is awesome. So this picture was actually made for by one of our patients. His name is Kate Mota, and then he made this picture for us, which I found amazing. I actually have a mug that one of my friends gave me. So this is the first type. We call it type 1. And as you can see, it's the smallest group in our cohort. So there's only 10 patients. And this is what we initially call the typical RP. And those are the patients that have saddle nose deformity, that have significant involvement of the ear, subglottic stenosis, tracheomalacia. These patients tend to have inflammation that is very severe, have high inflammatory markers, and these are the patients that get diagnosed the quickest, right? Because they have a lot of inflammation, things that you could see. The type 2 is the airway. So see, regardless of how you look at the data, there is an airway subtype in these patients. And patients in the type 2, they did not have saddle nose deformity of subglottic stenosis, but they have damage in the lower airway. So tracheomalacia and bronchomalacia. And then you see the ear involvement was less than in the other group. And the third group, we call it non-destructive. So these are the patients that do not have a lot of damage of the cartilaginous structures. But again, these patients don't have mild disease. When you compare these three groups, they all have tremendous exposure to higher doses of steroids and DMARS. And then I'm going to show you in the next slide also the disability. So although these patients at this moment, when we saw them, do not have cartilaginous damage, they can have severe disease. And then again, this was data that it was looked at one time point. So we don't know what is going to be the evolution of these groups, but we will know in a few years. So patients that have airway subtype have delayed diagnosis, and then as you could see here, more as compared to other two. You see the patients that have the type 1, they are the ones that have the shorter time to get diagnosed. And patients that have the type 1 have more complications, and that included more air trapping, thickening of the trachea, tracheostomy, and ICU admissions. But then when you take a look at the disability, patients that are on the type 3, they have 26% disability. So now I wanted to talk to you about the hematologic subgroup. So this is a figure that is taken from the manuscript that I mentioned to you before a couple of times from Dion and collaborators that included 142 patients evaluated retrospectively. And this is a picture of the cluster analysis. And I wanted to highlight to you the hematologic subgroup. So you see in here, these patients had myelodysplastic syndrome, cutaneous involvement. They die more. They have general symptoms, meaning fatigue, fever, myalgias. They do not have laryngeal involvement. They were more than 55 years old. They have more thrombosis. They were all men, and they did not go into remission. So now I would like to show you another case. So this is a 68-year-old male with fatigue, subjective fevers, sweet syndrome. He had ear and nose chondritis, very prominent, elevated inflammatory markers, and macrocytic anemia. And this is a picture of his ear, this is a picture of his back, and this is a picture of the bone marrow that is showing vacuoles in here. So what is this patient, what does he have? He has a somatic mutation in the UBA1 gene that has been associated with severe adult onset autoinflammatory diseases. And this syndrome is called VEXAS. So what is VEXAS? VEXAS is a new genetically defined syndrome that is due to a somatic mutation in the UBA1 gene in bone marrow stem cells. It has an overlap of systemic inflammatory and hematologic features, and it is severe and refractory and is often fatal. But this is the subgroup of patients, that hematologic subgroup that has been well known for many years in the RP world. And what does VEXAS stand for? So V is for the vacuoles that I show you in the bone marrow. E is because of the location of the mutation, which is in the E1 ubiquitin activating enzyme. X because it's X-linked. A because it's autoinflammatory. And S because it's somatic. So why is VEXAS important as a rheumatologist? And the reason that it's important is because many patients with VEXAS met diagnostic or classification criteria for rheumatologic conditions. This was the first cohort that was described that I just showed you in the manuscript, 25 patients, and 60% of these patients have relapsing polychondritis, 32% of the patients have sweet syndrome, 12% of the patients have polyarteritis nodosa, and 4% have giant cell arteritis. So of course, I'm interested in the patients that have relapsing polychondritis. So how is this really relate VEXAS to RP? Well, we want to take a look at this particular subgroup of patients in our cohort, and then we found that 8% of the patients with RP have VEXAS. We included 92 patients that we have seen prospectively, and for those in that cohort, 7 of them were confirmed to have VEXAS. So now I'd like to show you some data about patients with VEXAS. So these are the demographics. These patients have diagnosis late in life. So this is the age of disease diagnosis. You could see it's 64. They're all male, they were all white, and these are the different diagnoses that they have. So relapsing polychondritis, sweet syndrome, they also have myelodysplastic syndrome, multiple myeloma, and MGUS. And these are the most common clinical manifestations of these patients. They have fever, skin involvement, and they can have mainly Sweet syndrome, but they can also have leukocytoclastic vasculitis, pulmonary infiltrates, ear and nose chondritis, and DVTs. And this is an example of the chondritis in patients with VEXA, so very prominent on the ear and the nose. This is an example of the pulmonary infiltrates that in some of the patients that had a biopsy, we were able to demonstrate that this is actually neutrophilic infiltrate. Now, the problem with these infiltrates is that these patients can get intubated because of the pulmonary infiltrates, and this it happened several times. So if you have a patient that you're suspecting that they have VEXAs and they have pulmonary infiltrates, they get better with higher doses of steroids. Of course, you have to rule out any infectious process, but this is mainly inflammatory. So we then decided to compare the patients that have VEXAs RP with patients that have RP in our cohort, and then we found that they are all male and they have an onset symptom, age onset symptom later in life. And then we look at the different airway manifestations, and then we found that patients with RP have airway involvement directly into the airway, the trachea, and the bronchi. We did not find any airway involvement in patients with VEXAs RP. What we do found, we did find the pulmonary infiltrates. So that's a big difference between these two patients that we think is very important. In terms of other clinical manifestations, patients with VEXAs have more fever, more ear chondritis, more pulmonary infiltrates. They have unprovoked DVTs, skin involvement, and then patients with RP, they have more airway chondritis and more joint involvement, like synovitis. Patients with VEXAs complain of musculoskeletal symptoms, but they're more like swelling or pain, but not really synovitis. So we then wanted to take a look at how you can identify these patients. I'm talking about patients that have VEXAs with features of relapsing polychondritis only. And we were able to identify these patients using clinical variables. This was done using a random forest. So in a patient that has ear and nose chondritis with an MCV more than 100 or platelets less than 200, you will have 100% sensitivity and 96% specificity to test positive for VEXAs. So this is something that I think is very important to keep in mind, to test these patients early, so then hopefully they can get treatment, and then we're working on possible treatments for these patients. So as I show you, this RP is more than one disease, right? And we demonstrated that, which is amazing. So now I would like to talk to you about one last case, and this is a 36-year-old woman that had ongoing dry cough and shortness of breath, and then her PFT showed air trapping, and she did not have response to bronchodilators, but yet she was diagnosed with asthma. And she had improvement of her symptoms with very high doses of steroids, but unfortunately, when she tried to calm down on the steroids, she started having costochondritis, anterior neck pain, bilateral knee swelling, arthritis in many joints. Interestingly, the review of systems was positive for ear pain and redness, nose redness and swelling. She actually recalls having people telling her at work that maybe she was drinking alcohol because her nose was so red. She had voice changes, intermittent episodes of arthritis that were self-limiting, dizziness, tinnitus, and many syncopal episodes. And this patient, this is me. So as Christina was telling you at the beginning, I initially did critical care and infectious diseases. And when I was done with my fellowships, I was like, I actually said, I am not going to do research anymore. I am going to be a clinician, and I'm going to work in infectious diseases and do my ICU. And then I got relapsing polychondritis and got extremely sick. So this is me coming out of the ICU, my first ICU admission, many more to come after this. So this is Samir Kadri, which is one of my ICU ID critical friends, and then critical care ID friends. And this is one of my best friends, Danny Jaswal, which is ICU nephrologist. So I've been very lucky to have a lot of people helping me through this. So what do you do when something like this happens, right? I mean, you are done with your fellowship, you want to go on with your life, and then you get this diagnosis. And as a physician, like, I think that maybe of probably you will do is just go and read everything that is available in the literature to try to understand your condition and try to see what can you do, how you can get treated, and all of that. And after reading about relapsing polychondritis, I was very I don't know if I call it disappointed, but it was like upsetting to know that the disease has so many challenges, right? I also joined the Facebook support group, which was amazing, extremely helpful, wonderful people that I've been able to meet there. So I realized that RP has a lot of challenges, as I show you through some of them during this presentation. So the first thing is that the diagnosis is purely clinical. Right, you don't have a blood test that can give you the diagnosis of RP, and the symptoms, as I show you, they're very heterogeneous. And yet, you make the diagnosis in clinical manifestations, but we do not have a definition of organ involvement. Now, the disease is very variable in terms of severity and response to treatment because since the beginning, when I learned about this disease, my thought was always like, this has to be more than one condition. It doesn't make any sense. And I think that we're getting to prove that. There is no classification criteria, so you can't do like a research, because how you're going to have an homogeneous group of patients to study. So there is no clinical trials, there is no homogeneous patient population, there is no validated disease activity measure, and there is poor understanding of the pathophysiology. So after all of these, what I felt was that the state of the art for the diagnosis and treatment and management of RP was basically shooting in the dark. So anyway, when I was diagnosed with this, my thought was that we're basically shooting in the dark, right? I mean, this is like, we have no idea. So I'm standing there thinking, what are you going to do with this, right? And knowing NIH and knowing all the resources that we have, my only choice was just to move forward, right? You need to move forward, because since I thought about this a lot, right? So we needed to move forward, and my goal was always to improve morbidity and increase survival in patients with relapsing polychondritis, and that is what I thought that I wanted to do, because it's a very difficult disease to have. So being a physician and being a patient and having an understanding and learning the stories also from the relapsing polychondritis Facebook support group, there was no other choice for me. So I wanted to have a magic wand, and I'm sure that many of you also want to have a magic wand, because we have so many patients that you just want them to get better right away. And I am very impatient. Actually, being a patient is not a good word, because then, or maybe it is, right? Because you're supposed to be patient when you're a patient, but it's just very difficult, not only as a patient, but also as a physician, and knowing how much suffering you have. So I'm sure that many of you may also have this magic thinking at some point of having a magic wand. But yes, it is magic thinking. So we do not have a magic wand, but I had NIH, which to me was my magic wand. What was the stone, the source of support and help that we needed to be able to move the field forward in relapsing polychondritis and help these patients. So I had a lot of help from a lot of people. So here's me asking for help from everybody, and that's the only thing that I have found at NIH. Not only on the clinical center, but at NIAMS. So the only thing that I have found at NIAMS is a lot of support and encouragement, starting with James Katz, which was the physician who diagnosed me and helped me, and it was the program director and helped me through the fellowship. Henry Masor, which is the chief of the critical care, that has been my mentor and has been supporting me and encouraging me, and Anthony Suffredini, which is the deputy chief in critical care. So these two people did call me crazy at the beginning, but I think that they always supported me, particularly when I have been very sick. And of course, Peter Grayson, which is my mentor and my friend, that helped me tremendously during my fellowship and continues to help me and support me to be able to do this and continue with our purpose. So during my rheumatology fellowship, we were able to develop the first known prospective cohort of patients with relapsing polychondritis. And I'm just going to show you briefly what is the evaluation that these patients get when they come to NIH. So they get a complete clinical evaluation that include patient surveys and, of course, rheumatology, ENT, and audiology to have a better understanding of the organ involvement and any super specialists that they need. With this, we get a lot of detailed clinical data to assess disease activity and understand the disease over time. And we do take a lot of blood primarily to evaluate the patients clinically and also to do research, of course. So we have our biospecimen repository to study the disease, and we do a lot of diagnostic tests, again, to assess the organ involvement in these patients. And this is helpful in so many ways. So it's helpful because it's going to show us the disease over time, and then we're going to have a better understanding of the disease over time. But to me personally, is extremely helpful for the patients directly, because we're able to evaluate these patients and provide data in a short period of time that I think that is very important and sometimes critical for their management. So NIH is amazing, and we have been able to do a lot of work there, but there is still a lot of challenges, right? We don't have classification criteria. We don't have a lot of tools that we need. So there is a lot of hurdles that we still need to cross. And we had an understanding of this since the beginning, that this is a rare disease, and then we needed to reach out to all the experts in the world that have been seeing patients with relapsing polychondritis for many years. So we knew we needed to work together. And because of that, we did that. We reached out to all the experts in the world in relapsing polychondritis, and we created the International Relapsing Polychondritis Research Network. And this is the picture of our first meeting, which was in November 14, 2016. Then here's Peter, this is Chikazi Hajime, this is Michael Lin from the Relapsing Polychondritis Foundation, Robert Colbert, a lot of wonderful people. So it was very small, our first meeting. It was like very spontaneous. But what happened since 2016 until now, and is that our group has expanded tremendously. These are all the countries that now belong to our international group. We have physicians with multiple super specialties, and more importantly, we have patient representatives. And then we have had the support of the Relapsing Polychondritis Foundation. And there is a very nice video, if you want to look it up on Google, of our last meeting in person, which was in 2019. And during this meeting, we work in the classification criteria project, which we are submitted to the ACR-ULR, and hopefully we will get funded, but we're still waiting to know the answer. We also work on the Relapsing Polychondritis Disease Activity Index, and we're planning to work on the Relapsing Polychondritis Damage Index. So I think that anything that you wanted to do is absolutely possible. You just need to make the jump. I made a big jump, but I am very lucky because I had a lot of people that helped me and support me and made all of this possible. So in summary, relapsing polychondritis is a heterogeneous disease with multiple clinical manifestations, including isolated airway chondritis. ER chondritis can happen late in the disease, and it has a wide range of clinical presentations and characteristics that go beyond the triad that we all know. Mytic syndrome may be its own entity, but we're still looking at that. And VEXA syndrome is the cause of RP in 8% of the patients. And I would like to acknowledge a lot of people. I think that when you acknowledge people, you should be able to have like 10 slides. But of course, the clinical center and all the people that I have worked with, and the people that NIAMS, particularly Peter Grayson, Emily Rose, which have done a tremendous work in relapsing polychondritis, Kaylin Quinn and Yiming, and from the NHGRI, David Beck, which was the person that led the genetic discovery of the VEXA syndrome, and everybody, Dr. Kasner, Mandy Umbrello, and the VEXA team, which is a huge team. And the International Relapsing Polychondritis Research Network, as well as the Relapsing Polychondritis Foundation, but most importantly, our patients. And I'm open up for any questions.
Dr. Ferrada, I know, high-dose steroids is obviously something that we use in relapsing polychondritis. Is there anything new in the pipeline that you know of as far as disease modifying of any kind?
Well, it depends of how the organ involvement of the patient. So we don't have at the moment yet any particular guidelines of how to manage these patients. I think that is very patient dependent. But we do use a certain type of biologics more than others, depending on the clinical phenotype. For example, patients that tend to have more sacroiliitis and maybe we do TNF inhibitors, and then patients that have elevated CRP and have more airway involvement, we tend to do tocilizumab first.
Yeah, great. Dr. Bunker had a question. He wanted to know about any potential biomarkers for diagnosis or disease monitoring.
Yeah, we don't have any specific biomarker for diagnosis other than the subgroup of patients that have VEXAS, right, that they have a genetic diagnosis. Other than that, in the other subgroups, we do not have at the moment a biomarker. And I know that collagen 2 has been known historically to be an antibody that you can test in patients with RP that can help with the diagnosis, but we have not seen that in our cohort. And based on what you find in the literature, I don't think that is a good test to diagnose relapsing polychondritis.
Thank you. Let's see. Another question coming from Alicia. She said, hi and thank you. And then wanted to know if you could speak further to possible triggers for episodes and the possibility of light exposure as a possible symptom trigger.
Yeah, we have seen different patients have described different triggers of the disease. So as I mentioned to you, some of the aggravating factors for the ER, it has been minimal trauma. Interestingly, many patients have said that when they eat red meat, they can have a flare. Also high doses of sugar, and some of the patients may have said sun exposure, but there is not a consistent particular trigger, but those will be, and traveling.
So as you describe somebody that has, say, VEXAS, or somebody with Magic syndrome, where they have sort of distinct describable subtypes, does that then pull them out of your denominator because of like all the different types of, or I guess, clinical phenotypic expression for RP? Because I guess you're stuck, right? Because you have a clinically described syndrome and you want to include as much data as you can. But
so I think that moving the data that I show you on those 3 clinical subtypes, that included only 2 patients that had VEXAS at the moment, because that was done like that only included 72 patients. We're up to 92 adults at the moment. And the patients that had VEXAS, based on their clinical manifestations, they were classified as the type 3 because they didn't have any organ involvement. So I think that it is a little bit tricky because it will depend on the variables that you decide to include in your analysis. And then for the late in class analysis, we decided to include anything that it was objective related to cartilage inflammation. But I think that if we take a look at the patients, for example, if we use a different set of variables and we want to take a look at mucocutaneous involvement, the clustering may be different.
We have another question here. Teresa wanted to know, how do you suggest treating everyday pain in the nose and ears? She's on Plaquenil methotrexate, but still has fairly severe nose pain.
Sometimes you could use local treatment for the pain. I will advise you don't to ever put anything inside your nose because it really burns and you cannot get it out. I've done that and it's not good. But you could put, like for example, Voltaren gel can help for the nose and for the ears, or you can also use lidocaine for local treatments.
We have another question that came through. First of all, I want to thank you. This is Camellia. Thank you for the talk. And do you have any information on Avacopan, maybe in an RP?
Yeah. We thought about that and we discussed about that, but we don't have any data on that yet. But yeah, it's a good thought.
You spoke some to this about your personal experience. How does that affect how you approach patients in any way?
Well, I've been doing this already for several years, and I'm always been since the beginning aware of the potential bias. That was The reason that I did the rheumatology fellowship was because I needed to have the knowledge that I required to treat these patients as objectively as possible, make sure that I wasn't going to miss anything. But again, I'm very lucky, and I work with like wonderful rheumatologists that help me making sure that I'm not missing anything. And in terms of how having relapsing polychondritis, I don't think that it affects the relationship. I just think that it makes it different because it's a different connection when you talk to the patients. And sometimes, I mean, I understand when they tell me, I feel that somebody's choking me, and I was like, yeah, I know what that means. So it's a very different relationship that you have. I always had a very close relationship with my patients, and this has made the relationship even closer. And I am not happy I have relapsing polychondritis, but it has been helpful to try to understand the different symptoms.
Just a follow-up question from Alicia. She wanted to know if there was any evidence of light exposure as a symptom trigger. Any clinical or research evidence of that?
We don't have that evidence in RP, but I think that many rheumatologic conditions are very similar, right? I think that, I mean, if you take a look at RA, if you take a look at lupus, there are triggers that it seems to be consistent within all the rheumatologic conditions.
Sure.
But
absolutely.
yeah, that's a very good question. I think that we should look into that. Yeah.
Alicia also wanted to know, do you have any thoughts on connective tissue involvement in RP?
Yeah, so it affects all the joints, as we were saying, like it doesn't really have a predilection for any particular joint. And then I also think that it affects the structures around the joints. That's why it's not really erosive, because I don't think that, yes, you have synovitis, but it's more like tendinitis. So patients will have many episodes of multiple tendons being inflamed, and that's why also dactylitis. So I think that it goes beyond the synovium. And interestingly, when you take a look at the knee effusions, they're cold. So I don't know if it's just because it's a particular inflammatory process towards the cartilage instead of being the synovium.
More periarticular, maybe?
Yeah, yep.
Yeah. Sheila would like to know, is NIH still doing any studies?
Yeah, of course, we are seeing patients with relapsing polychondritis, which we're a little bit backed up because of COVID, but we are, I mean, we're getting records, reviewing records, and getting ready to when we're going to be open for everybody. Yeah. But yeah, we are seeing patients.
Great. Dr. Bunker wanted to know, sounds like RP patients are initially misdiagnosed as asthma, or a lot of them are and can be. And are there any pearls to how we can correctly diagnose the airway disease in relapsing polychondritis?
So an interesting and I think that unique finding in these patients is that they don't respond to bronchodilators as you expect. And they can also have, some of them can have a paradoxical response to bronchodilators. So instead of getting bronchodilation, they get bronchoconstriction. So that could be a clue, so no response to bronchodilators, requiring very high doses of steroids. So when you treat asthma, you don't really need 60 or 80, right? But when you have a patient that has RP, it seems that the dose that they need to be able to control the symptoms is higher than what you need when you have a patient that have asthma. So difficult to control asthma. And of course, doing a very good review of systems that I think that sometimes, and then, I mean, a patient won't like tell you this information unless you ask, right? I mean, if they won't tell you like, oh, I have pain on my ear, I have pain on my nose, or I have pain on my back. They won't say it unless you ask them. So I think that sometimes when we go into super specialties, we tend to concentrate in that particular organ. And then maybe that could be one of the factors that is contributing to delaying diagnosis in this particular type of patients with RP.
Great. So Andrew Ross says hi from Trinidad, in the Caribbean, and wanted to know, is there any connection of RP to the gut microbiome, or has manipulation of the gut microbiome been considered as a treatment? He notices when he alters his diet, he sees improvement.
I know that is something that many patients have reported. We are going to be looking into that in collaboration with UPenn, in particular the microbiome, not the gut microbiome, but other microbiome. But I think that is we don't know. There is a study actually from Shimizu. This was from 2018, and I can send it to you if you give me your email, where he actually looked at the microbiome, and there was a regulation with the T regulatory cells. So he actually looked at the different type of flora, and he found a connection between the percentage of the flora in the microbiome and the upregulation of the T regulatory cells. And he did this by looking at IL-10 also as well. So then I can send you that article. That is only 10 patients, but that is the data that I recall from the gut microbiome.
What do you think about hematuria in RP?
We haven't seen that in our cohort. There is only a few patients that had hematuria that we have seen, and then we found other reasons for the hematuria. There was only one particular patient that had it that we didn't know what was the cause. Renal involvement is in RP. I think that is very controversial. We do not believe that the kidneys really get affected directly by RP, and if it does, it's a very, very, very small percentage of patients. The kidney involvement in RP, I think that it was before there was the definition, the difference between GPA and RP, because as you could see, they're very similar clinically, right? So if you don't have a difference in terms of a blood test that can help you with the diagnosis, they could be the same.
So Alicia was wondering about certain markers that might be reliable or aren't reliable for indicators of disease activity, such as complement levels, if any of those things are an indication of high or low disease activity, or in this, and her other question was in the sense of general autoimmunity activity, but in RP, I guess.
Yeah, so we have seen maybe a little bit of elevation of complements, but I think that happens in any inflammatory process. So I don't know if we can relate that directly to RP. In terms of other inflammatory markers such as ESR and CRP, interestingly, some patients that have RP with significant inflammation can have normal inflammatory markers. So we haven't been able to find a particular inflammatory marker that is going to be consistently elevated that can help evaluating disease activity in these patients overall. But we're going to keep looking until we find one.
Absolutely. Absolutely. Sheila wants to know if there's any way to predict kind of how the disease progresses, and what patients that you don't see progression with treatment.
Yeah, so we will need a few years to be able to answer that question. I think that patients that tend to have severe inflammation with high inflammatory markers and can have more damaging disease, and patients that don't have that fast progression, we still don't know where the disease are going to take them over time. I do think that treating patients aggressively to try to decrease inflammatory process can help, like in any other rheumatologic disease, can help with the progression. At least in my particular case, I believe that the fact that I have been receiving aggressive treatment has helped with some of the organ involvement, particularly the airway. Yeah.
Okay, and yeah, preventing progression of the disease.
I think so. Yes. Yeah. Yeah, and then in some instances, when you have any, for example, if you have inner ear, right? I mean, those patients, they just need to be treated aggressively. I mean, anything that you can do to the damage is secondary to the ongoing inflammatory process. Now, with patients that have airway involvement, I do think that maybe not particularly the patients that have the subpleuric stenosis, because that tend to be, again, more like aggressive and angry, but perhaps the patients that have the lower airways, such as the trachea and the bronchi, I do think that it takes a lot of time for that to get damaged, and many episodes, and I think that that's why also the delay. I mean, I don't think that it happens overnight.
Sure, yeah, makes sense. And for the bronchomalacia, that is generally seen on like pulmonary function testing, then it presents as like an obstructive pattern, or?
No. So that is something that, so the PFTs, right? So everybody is like, oh, you do PFTs and they look great, you're fine. I don't think so. You know, I think that sometimes, and then I think sometimes you won't see if you have tracheomalacia that is, for example, 60%. I don't think that you will be able to see the changes on the curve that are going to tell you that you have malacia. Right, I think that for you to be able to do that, you really need to have a lot of obstruction, which you don't want to get there. So we're still in the process of trying to figure it out what would be the best objective tool that we could utilize to detect disease earlier before you get up to 80% tracheal collapse. So PFTs is a test that it was, although so old and well studied, it was developed and is being used for a different disease, right? This was developed for COPD and asthma, not for RP. So there is a particular number that we look at distal airway disease, which is the FEVF 2575, which is a surrogate of distal airway inflammation, mainly used in pediatric patients more than adults because it's so variable. But that is something that we'll look at. And the air trapping, right? If you have very high like RV-TLC ratio, that is an indication that you're having distal airway.
Okay, gotcha. Sure. Other than, you mentioned the dynamic CT imaging that you guys do there at the NIH, which I guess we could do really anywhere, or is it like a very specialized dynamic CT that you guys are using?
We use a different machine, so it's called a Toshiba CT scan, and it generates a video, the video that I show you. But I think that any institution should have the capability to do a dynamic CT scan. The problem is that the technique needs to be done properly, because if you take the image not when you're excelling, then you will have two ecstatic images, and it's not showing you what you're supposed to. So I think that any hospital can do it if you talk to a radiologist and make sure that the protocol is being done properly.
Yeah, certainly. Yeah, we can do dynamic CT. It just, I guess the difference is it's not in a video form. It's, you look at the serial images. Yeah. Okay, gotcha. Research on possible connection between vitamin D and cartilage protection and restoration. Do you think that there could be something going on at the basic level with vitamin D production and use in your body when it comes to RP?
I haven't looked into that. That's a very interesting question. I haven't seen any articles related to vitamin D. I think vitamin D is good for everybody anyway. But I don't know the particular relationship between vitamin D and cartilage. But I think everybody should take it, particularly during the winter.
I guess a question for you, I apologize if you mentioned this already, but in patients with airway disease, is there a specific biologic that you've found the best success with, or?
Tocilizumab, and I have talked with other physicians that have also seen that. Yeah, but I think that it depends. I mean, when patients have recalcitrant disease, I don't think that one single agent is sufficient. Probably need to use at least two.
Okay. We have a question from Geraldine. She wanted to know if there's any indication that RP is hereditary, or any, I guess, genetic markers you've been.
We haven't found hereditary, and the mutation that we just recently described is somatic, meaning that is acquired. So we're looking into the possible connection with, and we have children, so it may be, but we don't have confirmation of that yet.
Let's see, we have another question here. Would you say that treatment with AZA 2 mg per kg along with prednisone 15 a day is working, or would you see an alternative to AZA if someone was failing that management?
I think that there are other options that you could be used, but I think that maybe you need to talk to your rheumatologist. And I would be happy to talk to your rheumatologist about possible options of treatment.
So Andrew Ross wanted to know if it's possible for someone who's outside of the United States to visit at the NIH and to be a patient there, I assume is what he means.
Of course. We have patients from many places outside the United States. Anybody can come to NIH.
Andrew's last question was, how can he go about coming to the NIH? How can he, make an appointment or come see you guys?
Yeah, so you can email our research nurse, and I think that all the information is in the Relapsing Polychondritis Foundation. They have, her name is Wendy Goodspeed, which is amazing. She's the most amazing nurse in the world. And she will get your records, and then we'll review your records, and then we start the process.
Fantastic. And Dr. Bunker wanted to know, when you do an MRI at the, like the sternocostal or costochondral joints, do you see changes like bone marrow edema that you know, goes along with disease activity, and we know when patients are having pain in those joints?
We have not done MRIs consistently to answer that question. We may be able to see that, but we haven't done MRIs on all the patients of the chest that have active costochondritis to know if that is the case. I do think that perhaps a useful tool in the future could be ultrasound, if we could, and then also to look at the cartilaginous structures that are outside the airway. For example, the thyroid cartilage. I think that if we could figure out a way to have a look with an ultrasound and then see if there is any activity there, that may be very helpful, particularly for costochondritis, right? Because costochondritis is such a common symptom also for other diseases and other diagnoses. So I think that I agree with you. Having an objective tool to look at it would be great, but the MRI, we don't know.
Thank you so much for coming and staying and answering all of our questions, and for a great presentation today. We really, really appreciate it, Dr. Ferrada.